Axel, and today I'll be presenting on efficient deep learning for point-of-care pneumonia screening. So what is the problem? In many healthcare systems, there can be a significant gap between where the patient is and where the diagnosis happens. Consider a scenario where a district hospital has X-ray machines and radiologists, whereas a rural clinic that it serves has only nurses and lacks equipment. That would mean hours of travel for the patient and possibly days between actually getting a diagnosis and having the scan. For a condition like pneumonia, where early treatment significantly improves outcomes, that kind of delay is costly. So the question becomes, could we bring diagnosis closer to the patient? The opportunity is point-of-care diagnosis. If you imagine a scenario where a rural clinic has basic X-ray equipment or a mobile X-ray unit visits periodically, if a nurse can capture an image and get an instant AI-assisted interpretation, patients could be triaged on the spot without necessarily needing a radiologist on the site. But this introduces technical constraints. In a clinic that only has access to low-spec laptops or tablets, heavy models may not run, while clinics that don't have dependable access to internet, well, cloud-based inference doesn't work there. For this kind of deployment to work, you'd need models that are efficient enough to run on constrained hardware and are accurate enough for clinical deployment. The stakeholder in this scenario would be healthcare NGOs or government health ministries looking to deploy AI-assisted screening access to a network of rural clinics. The requirements of these stakeholders would likely be on-device inference, so they wouldn't be reliant on internet connectivity, compatibility with low-spec devices or hardware, so that clinics can run these models on hardware that they already have. Another requirement would obviously be clinical reliability with a focus on AUC, which we'll come to later, and a fast enough inference time that one could do many screens per day without creating bottlenecks. My proposed solution is to leverage recent efficient architectures that are specifically designed for edge deployment. I've compared three models. ResNet 50 is my best baseline, and it is a well-established convolutional neural network that comes, unfortunately, with a lot of parameters and therefore a lot of computational cost. EfficientNet B0 is my second model. It is a well-established, more efficient model, but it is, at this point, quite old. So my third model is a MobileNet V4, which is a much more recently released model by Google, also much lighter than EfficientNet. I evaluated these models on the Pneumonia MNIST dataset, which is a set of around 5,800 chest X-rays, which have labels pneumonia or not pneumonia or normal. The metrics that I used were accuracy and AUC, as well as parameter count and CPU inference time. In terms of results, let's start with clinical performance. ResNet 50 received the highest accuracy with 89.74%. That is followed by MobileNet V4 with 86.86%. And finally, we have the EfficientNet model, which came in just after that with 85.26%. There's an interesting insight, which is that MobileNet V4 actually received the highest AUC of 0.9605, which when compared to EfficientNet, which came in second, has a 0.9575 AUC. In a screening context, we care about the model's ability to discriminate between positive and negative classes across all thresholds, not just one decision boundary. And AUC is able to capture this, and by that metric, MobileNet V4 is actually outperforming ResNet 50. In terms of efficiency, ResNet 50 is the biggest model in this scenario by far with 23.5 million parameters, and it takes 61 milliseconds per inference on a CPU. EfficientNet comes right after that with a parameter count of 4 million, which is much less, and it takes 35 milliseconds to run on a CPU. But MobileNet V4 is again the superior model. It is just 2.5 million parameters and naturally takes 14 milliseconds per inference to run on a CPU. Now that's 9.4 times smaller than ResNet 50 and 4.2 times faster on a CPU. In terms of the trade-off between accuracy and efficiency, this scatter plot visualizes that. The top left corner represents the fast and accurate ideal model, and the bubble size represents the size of the respective model. It is clear that the MobileNet v4 is the model that is closest to the ideal. It's not the most accurate in raw terms, but it offers a good balance between clinical performance and deployability. To conclude, MobileNet v4 could enable deployment scenarios that wouldn't be possible or practical in other architectures. It matches ResNet 50's clinical utility and actually exceeds it on AUC while running much faster on CPU. In a scenario where clinics have limited hardware availability or unreliable internet connectivity, this kind of efficiency comes in super handy and could make same-day point-of-care diagnosis totally feasible. There are, of course, limitations to this. Pneumonia MNIST is a small benchmark dataset, and a real deployment would obviously need more validation on much larger clinical data. And a screening tool would only be useful if it was integrated into clinical workflows with appropriate oversight. But to the broader point, efficient architectures have improved to the point where the trade-off between efficiency and accuracy may no longer be a barrier. And what was a research result 5 years ago could now run in a rural clinic. Thank you for listening to this presentation.